type 1 versus type 2. So they used to call type 1 juvenile diabetes and type 2 adult diabetes. And while it is true that most type 1s are children, and you usually see the diagnosis under 40, and most type 2 diabetics are adults and very, very common in seniors. About 25% of those 65 and older have type 2 diabetes. Juvenile and adult aren't really true anymore. Number one, children are becoming more and more obese and unfortunately getting type 2 diabetes, which is related to weight. And then you also see a few adults, young adults typically, that develop a late onset type 1 diabetes. So there's a little bit of overlap, and that's why we use the term type 1 and type 2. So again, type 1 is usually in children, young adults, and the cause is much different. So it has to do with that there's not enough insulin. We don't really know what causes type 1 diabetes. There's some theories that viruses can start it. There's some other theories about food, but it's an autoimmune disorder likely. What that means is the body thinks that the pancreas, which is the gland that produces insulin that everyone has, is somehow an invader, and so starts using its own immune system to attack it. And the cells in the pancreas called beta cells get destroyed, don't produce insulin. So unfortunately, type 1 diabetics require and need insulin to survive. Type 2 diabetes is a little bit different. Their insulin is there, and in fact, early on in the disease, there's a lot of insulin. The problem is that type 2 diabetics can't use it. They're become insulin resistant. So even though the body has enough insulin, it can't use insulin. And what insulin does is it takes the sugar from the food that we eat and gives it to the cells, puts it into the cells for energy so that we can grow and survive. And so the type 2 diabetics have insulin, they just can't use it. And why can't they use it? Why do we become insulin resistant? And there's a lot of factors. Genetics is one component, and certain ethnicities have a higher incidence of type 2 diabetes. Certain families, it runs in families, but it's mostly related to weight. There's something about being obese, having excess fat. The theory is that fat gets oxidized, and the oxidized fat destroys the cells, making them resistant to insulin. So most type 2 diabetics actually don't need insulin. That being said, if type 2 diabetes is present for years and years and untreated, then those beta cells, those cells in the pancreas that make insulin, eventually get tired out. And so there are many type 2 diabetics that over time require insulin. But that's the main difference between the two, type 1 and type 2 diabetes. All right, so why do we need to treat? What do we treat? Why do we treat type 2 diabetes? You actually rarely do not die of elevated sugar. So we tend to focus on sugar because sugar is elevated in diabetes, but high sugar doesn't kill you. Very rarely does it do that. So you can certainly get instances where sugars are in the 800s or 900s and you can go into a coma, so it can happen. But mostly when it's not the sugar that kills you, it's the complications from diabetes that cause disease and ultimately death. And so the reason why we treat diabetes is not to get your sugar low, though that's a part of the treatment, is to prevent these complications of diabetes. And you can break down diabetes complications into two things, what we call microvascular and macrovascular. Microvascular are the small blood vessels in our body that supply various organs. And so the blood vessels in the eye are damaged with type 2 diabetes, and type 2 diabetes is one of the leading causes of blindness. The small vessels supply the nerves, and so you can get what's called a diabetic neuropathy. It can cause pain, and patients with diabetic nerve pain or diabetic neuropathy can suffer greatly. It also causes decreased sensation, and so because diabetics don't heal very well as well, they can injure their foot and don't even realize it. And that diabetes is one of the leading causes of amputation. And finally, the small vessels that supply our kidney, diabetes is one of the leading causes of kidney failure. And so you can lose your kidney function and be on dialysis like in the picture. So those are the microvascular complications. And then macrovascular are bigger blood vessels, and damage to the bigger blood vessels caused from diabetes leads to heart attack or stroke. And those are the biggest risks for death for patients with diabetes is heart attack and stroke. And so while we focus on sugar management, we're really treating diabetes to prevent these complications, to prevent kidney failure, to prevent blindness, to prevent neuropathy, and to prevent heart attack and stroke. And so that's why we treat type 2 diabetes. And so therefore, when we think about how do we treat diabetes, it's more than just treating the blood. It's more than just treating the sugar. There's lots of things. First of all, we need to diet and exercise, not only to lower the sugar, but to lower the risk of these things that I just mentioned. Smoke also leads to vessel disease and kidney disease and heart disease and stroke. So if you're a smoker and you're a diabetic, that's a double whammy. So you got to stop smoking. The other things that lead to heart attacks and strokes are blood pressure and cholesterol. So while we always want to treat high blood pressure, it's more important in type 2 diabetics to treat that, to monitor and treat the blood pressure to prevent the risk for heart attacks and strokes. Similar with cholesterol, you know, even while we usually use cholesterol-lowering medications to treat high cholesterol, cholesterol is such an important factor that pretty much every diabetic, regardless of their level of cholesterol, needs to be on a cholesterol-lowering medication. In addition, we want to check on these organs that are at risk for damage. So every diabetic needs to see the eye doctor once a year to look for those early signs of diabetic eye disease, because there are treatments available, but we have to go see the eye doctor once a year to get what's called a dilated fundoscopy, to have the eye doctor take a really good close look. Kidneys need to be checked once a year for early signs of kidney disease. There are a couple, in addition to treating diabetes, there are other treatments for kidney disease that can be helpful, so picking up that early. Diabetics should get their foot checked regularly, either by their primary care physician or by a podiatrist, to make sure there's no damage to the feet, because again, you don't always look at your feet, and diabetics, if they have neuropathy, can't always feel their feet, so you don't know if something bad's going on. So you also need to check the feet. So those are the major treatments, the major focus of treatment for diabetes: diet, exercise, not smoking, treating high blood pressure, controlling the cholesterol, checking on the kidneys and the eye and the feet, and then also checking the sugar. So it's not that sugar is not important, but it's not the only thing that's important. We have to focus on all these other things as well. Now, one of the questions I always get from patients is, do I need to check my own sugar? And the answer is usually not for type 2 diabetes. Type 1 diabetes is different because type 1 diabetics need insulin, and insulin can increase your risk of low blood sugars. And so if you're on insulin, then you need to check the sugar. So again, as I mentioned, many type 2 diabetics are able to get control without insulin. And so if you're not on insulin, or there's another medicine called sulfonylurea, glipizide is an example, we'll come back to that in a second, that can lower your blood sugar. So as long as you're not on insulin or a sulfonylurea, you really, in my opinion, don't need to be checking your sugars all the time, which can be very scary for patients. It's a, you know, in addition to cost, it's a big hassle. People get really worried about it. So no, you don't have to check your finger sticks with these monitors and stuff like that if you're a type 2 diabetic and are not on insulin or not on a sulfonylurea. What we do need to check is a hemoglobin A1C. Hemoglobin A1C is a blood test that your doctor does or the lab does, not that you prick your finger, but a regular lab test that helps determine how your overall sugar is controlled. And so basically a normal A1C is about 4.5 to 5.5. Anything over 5.6 to 6.5 is considered pre-diabetes. Once you hit 6.5, that's considered diabetic. And then when we have someone who's diagnosed with diabetes, our goal is to get that A1C under 7, because we know that over 7 increases those risks of the things that I just talked about: heart attack, stroke, kidney disease, blindness, etc. So we want to keep the A1C at least below 7. So for people who diabetics we're trying to get control, we check it every 3 months. Once your A1C is at goal under 7%, we usually recommend checking that again. It's a blood test done every 6 months. But finger sticks, checking your blood sugar at home with your finger sticks, really only necessary for certain type 2s and type 1 diabetics on insulin. As I mentioned, there's a lot of things that we need to do, but diet and exercise are probably the two most important things, just in general, but especially if you have diabetes. And it's important to note that it's more about weight than about sugar, because again, remember, the primary problem with type 2 diabetes is not lack of insulin, but it's the inability to use insulin. And the ability to use insulin is affected by weight. So when the weight goes down, the body is able to use the insulin more, and that lowers the sugar. So it's not just not eating sugar. It's basically about lowering calories so you can lower weight. So if you're eating healthy and you can't lose weight, then even if you're eating healthy, you're probably eating too much. So there's lots of things that you can work with your primary care provider to get that calorie count down. One of the things I recommend to patients is to look for something called hidden calories. Hidden calories are things that you don't even realize you're having calories, like salad dressing. So salads are super healthy, but if you're putting high calorie dressing on it, that can make the salad actually very high in calories. Beverages are a good source of hidden calories. People don't realize, oh, I'm drinking juice. Juice is healthy. Well, juice is high in calories. Even though it's healthy, it's high in calories. And you may not need that. You'd be better off with water. Empty calories mean caloric intake without any nutritional value. A good example of empty calories is alcohol. So alcohol has no nutritional value, and it's all carbohydrates, so the body just converts it to sugar. So, just if you're drinking 2 or 3 drinks a day, just cutting that down will substantially lower your calories, will lower your weight, and allow your body to use the insulin that it needs better. So it's not just about not eating sweets, it's about basically losing weight. And part of that is making sure that if you have a diet, you stick to the diet that works for you. So if people can fast and do crazy diets, but if you're not going to stick to it, then it's not worth it. So you want to do something that's going to work for you, which in my opinion is generally eat what you like to eat, but just eat less of it and make sure it's healthy foods. But it's really about lowering the calories. And then finally, exercise. Also very important. You don't have to go join a gym though. It has more benefits than just weight loss, specifically for type 2 diabetics. One of the things that helps the body utilize insulin or beat insulin resistance is exercise, and it increases insulin sensitivity, just exercise alone. Again, you don't have to join a gym. It doesn't have to be ridiculously intense. Even the CDC recommends 150 minutes of moderate activity weekly. So that's about 30 minutes most days of the week, 5 days of the week. So if you're doing 30 minutes of sort of moderate activity most days of the week, 5 days a week, that's going to get you your 150 minutes. And so it's not that hard to do. One of the things I recommend patients is to consider getting a step counter like a Fitbit. Most phones have apps for free that you can do this. So if you keep your phone in your pocket, you can just use your phone, but you have these like wristwatches, or if you have the Apple Watch, that has that in it. But if you don't have that, you can get one of these Fitbit watches or Fitbit devices and count your steps. And if you're getting close to 10,000 steps a day, that's probably all that you need to meet that CDC recommendation of 150 minutes of moderate activity just with walking. Certainly that should be enough both for sugar utilization and weight loss. So diet, something that you can do, something that reduces calories, something that you can stick with, and exercise. Don't have to join a gym. 30 minutes, 5 days a week. Counting steps is a good way to do that. Both of those things should help overall health, as well as reduce your risk and complication for type 2 diabetes. All right, lastly, last few minutes, I want to talk about the medications for type 2 diabetes. And there's a lot of recommendations. The one that I use is from the endocrinologist. So the American Association of Clinical Endocrinologists and the American College of Endocrinology, the two academic societies for endocrinologists, they're doctors that specialize in diabetes. They come together once a year to generate guidelines. And they have guidelines for medications and specifically what to use. And so for first-line therapy, here's a list of their medications in order of recommendation. So then we'll go over all of these individually. So the first-line medication for most diabetics is metformin. It's been around for a long time. It's available generically. It works really well, not too many side effects. But interestingly, the next two medications are the newer medicines for diabetes, GLP-1 receptor agonist and SGLT2 inhibitors. And I'll talk about these medicines, but these are newer medicines. And the reason why they're listed higher has to do with the fact that these medications, unlike other medications, have proven to reduce heart attacks and save lives. And that's important. As I mentioned, the reason why we're treating diabetes is not for the sugar, it's to reduce the complications, of which heart attack and stroke are the most important one. And we now have these newer medications which have proven beyond lowering sugar that we can reduce heart disease. And so that's why the endocrinologists have recommended these newer medications over some of the older ones. So basically, regardless of what the sugar is, this is a new recommendation from the 2020 ACE guidelines that if you have established heart disease, heart attack or stroke, or at very high risk, if you have kidney disease or you have heart failure, you should start with one of these two or new medications. Even if you've already been on metformin or haven't started metformin, it's recommended that those people with the highest risk with heart disease and kidney disease be started on these medications, and this is a new recommendation. Other medications include the DPP-4 medications, and there are some other medicines as well that I can answer questions about, I won't spend time on, but the most important thing, in addition to these newer medicines having these improvements in heart attacks, is that the older medicine, SU stands for sulfonylurea. These are older medicines. They're very popular. Glipizide, glyburide, they've been around forever. They're at the bottom of the list, and they're at the bottom of the list for a couple reasons. One, they have caused hypoglycemia, which is the blood sugar getting too low. None of the other medicines listed cause the blood sugar being too low, which is why I said if you don't have to check your sugar unless you're on one of these medicines. And low blood sugar or hypoglycemia is more than just feeling bad and eating a piece of candy. It can kill you. And in fact, these medications, sulfonylureas, have death and heart attack warnings because of this risk. So the low blood sugar can be very serious. It can cause the need to go to the emergency room, hospital, or even death. And so because of this risk factor of low blood sugar and the severity of it, the endocrinologists in their guidelines recommend these as last line therapies. You should try all these other medicines before even considering some of these older medications. All right, so like I said, the first medication that's recommended is the GLP-1 receptor agonist. GLP is a hormone that we have in our body, and what it does is it tells the pancreas to release insulin when it needs it. It's very different than the sulfonylureas, which just tell the pancreas to release insulin all the time, or insulin itself. So it doesn't have a lot of the side effects, and again, can prevent heart attacks in certain patients. Most of these medicines are injectable. Some of them, the newer ones, are once weekly, like Trulicity. Victoza is another one that is a daily medicine. There's a couple of really good side effects from these medicines. Can upset the stomach a little bit, but one of the best side effects is it can lead to weight loss. And so that's a good side effect. One of the newest GLPs is Rybelsus. Rybelsus is the only oral agent, so all the other ones are injectables. We finally have an oral GLP-1, so that's really exciting. So that's something to consider. It's called Rybelsus. So those are the GLP-1s, the newer medications. The other new medications are the SGLT2 inhibitors. So SGLT2 is a receptor that we have on our kidneys that prevents us from losing sugar. These medicines block that. So essentially what we do is we urinate sugar, and that helps lower the blood sugar. But again, these are medicines that help prevent heart attacks and strokes. And why is that? We don't really know, but like the GLP-1s, they also lead to weight loss. Another thing that these medicines will do, medicines like Jardiance, medicines like Farxiga, will work. They work like a diuretic, so that they lower the blood pressure. They're a fluid pill, so that you lose fluid, and they can reduce blood pressure. So it's possibly weight loss or blood pressure are helping with these heart improvements. But these are also medicines to consider taking sort of first line, especially if you're at risk. I mentioned metformin. It's still considered a first line agent if you don't have risk for heart disease, kidney disease. It's considered first line. Can upset the stomach a little bit, but it's very effective. It is also generic. DPP-4 medicines block the breakdown of our own GLP-1. Like I said, we make our own GLP-1. The DPP-4 inhibitors block the breakdown of that, so it increases your own levels. Januvia is an example of a DPP-4 inhibitor. And again, like I said, there are other medicines that you can use, but glipizide or these sulfonylureas are now the last medicine because of the side effect and their risk for heart disease. So that is a very, very quick summary of sort of all the medications that you can take and where they're sort of recommended. I think that the new thing, the thing to take away, the sort of newest research, is there are two classes of medications, the GLP-1s like Rybelsus and the SGLT2s like Farxiga or Jardiance, that in addition to lowering sugar can prevent heart attacks, and that's why the experts sort of recommend them. And they're no longer recommending them, or they're recommending as a last resort these very popular medicines like glipizide and glyburide, because they don't have those improvements and in fact can cause some risk. So that's a very quick summary of the medication. So, in conclusion, I think we have about 5 or 10 minutes for questions. We talked about the difference of type 1 and type 2 diabetes. It's no longer adult and juvenile onset. There's some overlap. But for type 2 diabetics, it's not about not having enough insulin. It's about not being able to use insulin. And so insulin puts the sugar in our cells. And so diabetics have high levels of sugar. And while it's important to focus on sugar, really we want to treat the complications, heart disease, stroke, kidney failure, eye failure, things like that. And so while we want to focus on sugar, we also want to focus on preventing those complications. And how do we do that? We check things. We check the blood pressure. We check the eyes. We check the kidneys. We start cholesterol medicines. We treat high blood pressure. We stop smoking if we're smoking, and we focus on diet and exercise. Excuse me. As far as diet, again, it's not about sugar or eating sugar. It's about the weight. So we really got to get the weight down to improve insulin sensitivity. Same thing with exercise. You don't have to join the gym. Just even modest activity most days of the week is enough to help with the weight loss, to help utilize sugar. So that's recommended for all people. And then I spent the last few minutes talking about the medications. And the main thing was that there are these newer treatments, GLP-1s like Rybelsus or SGLT2s like Jardiance, that not only lower sugar very effectively, but can prevent heart attack. And the experts, at least in 2020, are recommending these much earlier and recommending older medicines like sulfonylurea, such as glipizide, much later, avoiding really if possible because they cause these low sugars.
Will Farxiga, Farxiga, will that help with edema?
Yes, so you pronounced it correctly. It's Farxiga. Farxiga is one of these SGLT2 inhibitors. So Farxiga, Jardiance, there's a couple others. And what they do is like I said, they block the kidney from reabsorbing sugar. So your kidney only pees out some waste products and some water, and so normally doesn't pee out sugar. And so what this does is that these medicines, these SGLT2s like Farxiga, block that mechanism. So you purposely pee out sugar. And so when you're peeing out sugar, you're lowering the sugar, so that's good. But you're peeing out two other things. Number one, you're peeing out calories, so it helps you to lose weight. But when you pee out sugar, it usually draws water with it, so it functions like a diuretic. So it lowers blood pressure, and if you have edema, it can also treat edema as well. And one of the things I mentioned earlier, again, I went pretty quickly, but one of the sort of predisposing conditions is heart failure. And so these drugs, these SGLT2s, are now being considered in heart failure even without diabetes, but certainly with diabetes because of their diuretic effects. And so yes, they can help with edema and fluid. So they're a good medication to consider.
All right, Dr. Mintz, you already talked about diet. I just have a question here. So as you know, there are quite a few, I don't want to call them fads, but different types of diets. I know you said it's more about just the amount of food you intake, but would you say there's any diets out there that you, as if you have type 2 diabetes, that you would stay away from?
Stay away from, no, I don't think well, let me think about that for a second. I think my recommendation for type 2 diabetes would be no different for people who are trying to lose weight, which is you should do the diet that you think works for you, that you're going to stick to. So a good example is there are people who swear by vegan diets, which means all vegetables, some fruits, but like no meats, no plant, no eggs, nothing, no fish, pure vegan. And they'll tell you that it's good for weight loss, it's good for longevity. And then on the opposite end of the spectrum, and they have data that shows that it's good for weight loss, good for longevity. And on the other end of the spectrum, you have ketogenic diets like the Atkins diet or the keto diet, where it's very low carbohydrate and all meats and proteins. And they too have data that shows that it helps lose weight and helps longevity. Well, they both can't be right. They both can't be right. And the reality is it really probably doesn't matter how much you eat or what foods you eat, but how much you eat. And so it's really about calories and gaining weight. So if you're a meat lover, going on a vegan diet's not a good idea because you're not going to stick to it. What you want to do is get a diet that you can stick to, and then also focus on the calories, because you can gain weight on a vegan diet, you can gain weight on a keto diet if you're having too many calories. So there's not like magic foods that help you lose weight. It's about calories. And there are some reasons to go with different various diets. Somewhere in between is the Mediterranean diet, which is low carb but not no carb. It's not vegan. It allows for some proteins, but it's not heavy protein. So that's in the middle. But all of them will work. But it's really more importantly like what you can do and what you can stick to.
What about 0-calorie drinks? I know you're really hitting water, which obviously makes sense.
That's a hard question. That's a super, super hard question. And the reason why is because normally, based on what I just said, you would think that 0-calorie drinks are the way to go. I said don't drink soda. Those are unnecessary calories. And what if I have a 0-calorie drink? Here's the problem. There's some research looking at zero artificial sweeteners that suggest it can be linked with both weight and diabetes. The mechanism is not clear. One of the thoughts is that while the 0-calorie drinks taste sweet, they don't fool the body. And so the body thinks it's having something sweet, but then realizes it's not. And that can cause cravings for sweets later on. And so they've done studies like in nurses, for example, where they've studied nurses, and drinking Diet Coke was associated with more weight gain, not less weight gain. So the jury's not entirely, clear, or I don't say the jury's out on this, but it's not entirely clear, whether the benefit of 0-calorie drinks is worth the potential risk of some of the other effects. So the best 0-calorie drink is water. Water has no negative effects. It's great. But whether or not, you should drink Diet Coke essentially is unclear. There are some potential risks. So if you could avoid it or minimize it and drink water instead, that would be better. But I can't say it's clearly harmful, but there is some concern. So I would try, 0-calorie drinks, I'd try to minimize if you could.
Okay. Last question, Dr. Mintz. If you could look into the future, are there any research or are there anything going on as far as the treatments for diabetics that excite you?
That's a good question. We have all these newer molecules now. The GLP-1s, as I mentioned, are very exciting. We finally have an oral agent, Rybelsus, so that's a little bit easier. And I think we'll see more research with these medications. So we have a couple for type 2 diabetes, some really good new agents in our armamentarium to treat patients. One of the things that excites me is more for the type 1, but it has to do with the delivery and measurement of sugar. So there are these figure stick free monitors. Freestyle Libre is one of them, where instead of pricking your finger to check sugar, you wear a little thing on your chest or your arm that continuously checks the sugar, and you can use your smartphone to see what the sugar reading is. Similarly, we've been with insulin pumps, that technology has gotten better. There are new things, they're like pods, similar to these glucose monitors. They like sit on without any hooks or wires or tubes, sit on your chest and deliver insulin. And I think they last for like a month. And the next step is to get these devices talking to each other so that you're continuously monitoring your sugar and you're giving yourself, automatically insulin when you need it, using your smartphone as sort of a portable computer. And so that's essentially an artificial pancreas. And so we're almost there. We're already seeing some of these in studies where, you won't have a kid will get type 1 diabetes and it won't be like this huge major concern. They'll be able to get their sugars under control and use these wearable technologies and get it under really good control without, worrying about, checking their sugar or what they eat and things like that. So the monitoring and the delivery of insulin, the monitoring of sugar and delivering insulin is really, technology-wise, has really gotten improved. And so that's very interesting. I'm excited about that.